Right, welcome back to the final part of the lecture on intraocular disease, where we're going to have a quick overview on posterior segment disease before we finish. So what are the take-home messages for this last segment? First thing is the DASL response we chatted about earlier when talking about cataract assessment should be part of your visual assessment. Very simple, and even if you can't see the retina, or even if you can't see the eye actually, so an RTA with a cat or dog with an eye completely closed or eye full of blood, then you should expect to see a DASL response with a bright enough light. So it's a very simple test and include it in your diagnostic arsenal. The brightest light you're going to find in your clinic nowadays is often the light on your mobile phone. So if you're not getting a DASL, your ophthalmoscope won't be bright enough. You really want a bright head torch, a thin-off transilluminator, which you can attach to your ophthalmoscope handle or your iPhone or your Android phone light. So that's the first point. The second point is if you can't see the retina or indeed the eye, then ultrasound is a beautifully simple tool to add to your diagnostic arsenal and is recommended and allows you to see the whole of the globe, also the retina, the vitreous, and how they relate to each other. When you start looking at the fundus, the retina, you'll get confused. You'll see it's very beautiful, it's very complex. You'll start to see things you're not quite sure if they're normal or not normal, and trying to work out the difference between normal variation and pathology can be a challenge. So the key to that is to look at lots and to learn to take photographs as well. And also to get some good books to refer to. The final point, which we're not really going to go through in detail in this slide, is just to remind you that there are certain drugs which are toxic to the retina. Enrofloxacin is the classic drug in the cat, so there is no, given there are other fluoroquinolones available, there is no diagnostic, there's no justification for using enrofloxacin in cats in any circumstances, to my mind. Ivermectin and some of the other avermectins, but ivermectin particularly, as well as causing CNS problems you might expect in collies, can also cause irreversible blindness in dogs. So sudden onset blindness in dogs where they come from a farm or a stable environment, we have ivermectin on your list. So we mentioned briefly about photographing the eye. This is not this lecture. There's another lecture which you did look about this, but just to remind you, if you go to the website, theiphone.com, there's lots of tips and tricks about how to use your smartphones to image the eye, which really help when you start to look at the fundus. And they can either be directly, in the same way you use a direct ophthalmoscope, as these two central images are, and the right-hand image, and you get beautiful detail. Or it can be an indirect view of the retina through a diagnostic lens, as we can see in this dog on the left-hand side. So I'd urge you to go to the website and to learn about how you can use your phone to help assist you in your journey through learning what the retina looks like. So the most important posterior segment disease I want to talk about is hypertension. This is the reason I became interested in ophthalmology. This particular slide is probably the key slide to my whole career, actually. This is my mentor, Professor Sheila Crispin, who's retired, very talented, lovely lady. And I remember seeing this slide, a presentation in Bravo, British Association of Ophthalmology, in in the early 90s, and her talking about this lesion here, this bullous retinopathy lesion. Looks like a donut. You see a central darker area surrounded by a less dense circular region. What this is a focal choroidal effusion. If you look at the tapetum of a cat, you can see lots of tiny little grey dots. Those tiny grey dots are perforations in the tapetum, and behind the tapetum lives the choroid, that vascular network which supplies the nutritional demands of the retina. As the choroidal vessel starts decompensating sustained arterial hypertension, they start to leak, and those tight junctions we mentioned earlier in the uveitis talk will start to leak proteins, and they would end up with edema, effectively a fluid accumulation, which will surround the choroidal vessels and then will leak through these tapetal perforations to cause these focal retinal detachments. These retinal detachments will be labile, so there may be one here at 2 o'clock in the afternoon, but by tea time there might be another one over here. This might change size and shape, and so expect these lesions to move around. And these bullous retinopathy lesions are the first visual sign of sustained arterial hypertension in the cat. And at this stage, the kidneys may still be normal, the brain may still be normal, and the other end organs which we see damaged in hypertension will still be intact. So this is you want to identify these lesions at this stage before they get to a more severe case, which is right-hand image where we have large retinal tears, retinal detachment, we've got intraretinal hemorrhage. And at this stage, we've also probably got kidney disease. We do see hypertension in cats, and it does present as retinal findings. They tend to be less spectacular, tend to be a little bit more. We tend to see hemorrhage, small intraretinal hemorrhages as an earlier sign than these effusions we see in cats. So I'd urge you to learn to look at the fundus of all your older cats. We're used to thinking about taking blood pressure, but we should also be looking at our funduses as well as part of our normal clinical exam. We've mentioned PRA already with our little poodle who was blind in cataract assessment. Again, just to we see this less as time goes on because we're aware there's DNA screening programs for PRA, and as well as the eye test run by a bunch of talented eye vets around the country who will look at dedicate their lives to looking at pre-breeding examinations for dogs across the UK and Europe and America actually. These again are Sheila's beautiful images. And we have a normal kaolin retina in the center, and then either side we have a loss of retinal vessels. We have an increase in pupil reflection and progression to blindness. This is a disease of the rods, so we see progressive loss of rod function, and rods are what we use for night vision. So we see night vision lost at first, you become nyctalopic or night blind, and they may be apparently completely normal in room light. Just when you can take them out for a walk at night, they suddenly become very blind. There's a long list of dogs who have inherited a PRA, so refer to your eye scheme list. Spaniels being one of the commonest ones. And again, we've met our poodle before with end stage with cataracts. This is the same thing we see in other breeds as well. This little dog presented for cataract surgery and sadly had non-functional electrically dead retinas due to PRA. When you start looking at dog retina particularly, you'll very commonly start to see these lesions. These are small focal lesions of hyperreflectivity, often with areas of clumping of pigment within them, or obviously over here. And these are scars. These are areas of inactive historic chorioretinal inflammation which are resolved, and commonly these would have been caused by worm migration in young dogs. So look out for those. And then leading on from the next group of disease I want to talk about is sudden onset blindness and sudden onset retinal blindness. And this is an unusual presentation that we see a lot in the eye clinic, which is dogs who become suddenly blind. And the two main differentials for sudden blindness, retinal blindness would be SARDS, sudden acquired retinal degeneration syndrome, and optic neuritis we'll touch on briefly in a minute. We've met this little poodle before with PRA, and we talked about how we did an ERG and found, rather than the lovely normal ERG, we found a flat line because at the end of a long retinal degeneration process. In SARDS, which you see predominantly in small white dogs, be it Westies and Bichons, but also in Dachshunds as well, and a few other breeds are overrepresented. These dogs appear with sudden onset blindness preceded in almost all cases by Cushing's-like symptoms. So often these dogs have a 2 to 6 month history of PUPD, of polyphagia, of increased weight, of decreased muscle tone in the tummy, so pot bellies. Some of them may have positive ACTH stimulation tests, raised out floss, and then a few months or longer after they develop those symptoms, they become suddenly blind. And sudden blindness, there's lots of discussion of what causes it. What we see classically is we see a dog who goes blind almost overnight, and when we see them, the retina is completely normal, the eyes look completely normal, no signs of glaucoma, no retinal detachment. And what we do with these dogs is we want to differentiate if there's no gross ocular reason for the blindness. We then need to look, is there a problem with the electrical function of the fundus or the connection to the brain, the optic nerve, or the brain itself? So to do that, we use our ERG. So this little Westie here is having his ERG. And we're seeing it sadly electrically dead retina, which is typical of SARDS. It's an untreatable disease. There are subsets of this disease we call immune-mediated retinitis, which may have some treatment options, but generally SARDS is an untreatable disease. And interestingly, shortly after the blindness, the Cushing's-like symptoms or before actually, will often resolve. So these dogs rarely need treatment for Cushing's, even though initially they may have a positive diagnosis. So the group of dogs where we see a normal, sudden onset blindness with a normal appearing retina is optic neuritis. We don't always, we can sometimes see changes in the optic nerve head. The optic nerve might be swollen, might be hemorrhage around it, might be focal detachment. These are actually equine optic neuritis cases where we've got round detachment around the optic nerve, or in this case, hemorrhage and a little bit of swelling. They often will again preside. They will both these patients would present with no dazzle response, dilated, poorly responsive pupils. But the optic neuritis cases may or may not have a swollen optic nerve head. So with the swollen optic nerve changes, it makes it easier to the diagnosis, but without the optic nerve changes, we can still see extraocular. So optic neuritis, in which case they look similar to SARDS cases, and the ERG is helpful for us to differentiate the two, because in those cases the retina itself is normal. It's just the optic nerves, so these they will often retain their ERG, so they often are peculiar looking. Lots of causes. It can be extension of central nervous system disease or septicemia. Focal GME is probably the commonest reason we would see optic neuritis in our patients. So that brings us to the end of our talk about posterior segments. So remember the dazzle response, remember the ultrasound, remember to look at lots of retinas and look for those early feline bullous retinopathy lesions, and remember to be careful with drugs such as Baytril and ivermectin in dogs. That brings us to the end of our intraocular disease lecture. Thank you for your attention. Please keep in touch. Please message me, email me anytime. We'd love to help, and thank you again. Good luck in your ophthalmological journey.